meeting, the first time that I've used the gavel of being mayor. Work session here on Tuesday, March 12th, 2024 at 5:30 p.m. Of course, we are here in the City Council chambers. Excuse me, I'm calling the meeting officially to order. We do not have clerk, so I'll do the roll call real quick. Nisley.
Here.
Tryon. Lucas.
Here.
Bowles.
Here.
Garrick.
Here.
Flanders.
Here.
Reeker.
Here.
Woods.
Here.
Thank you. Open Meetings Act. A current copy of the Open Meetings Act of the State of Nebraska is posted on the wall at the back of the council chambers. No formal vote or action will be taken at this meeting. I repeat, no formal vote or action will be taken at this meeting. This is a discussion, a presentation regarding health insurance renewal for the city of North Platte and its employees. I believe we are online, so YouTube is on. As we have always done during these work sessions, we will be less formal, so you don't have to request the floor. Just raise your hand and try not to speak over each other. If you have questions, please. Okay, gentlemen, you're on. Oh, excuse me. We do have dinner coming at 6, right? Yeah. There will be a plethora of pizza, so hopefully you've come hungry. And everyone in the audience is welcome to eat with us as well.
That was an option.
And I ordered extra green peppers just for you. All right, gentlemen.
Well, we appreciate. Oh yeah, I don't know.
Hold on just a second. Ashanti, go ahead. It's fine. Okay, now go ahead. She's quick. It won't take her long to set up.
Very good. Well, we appreciate everybody coming out. It's I make sure I turn all the TVs on. I know it's kind of hard to believe that we're kind of circling back around to renewal season, but wanted to go through the renewal. There's been a number of things that we've been working on this year in terms of just maybe some internal changes. We met with the insurance committee earlier today to kind of formalize maybe one more change that we had been talking about. So I'll get into that. But wanted to first and foremost start with the renewal and kind of where that shaped out this year. Talk about the carrier that we're ultimately recommending and, just make, again, that recommendation. As you know, each year we take the city of North Platte out and we shop the reinsurance. So the wonderful thing about being self-funded is that, sorry. We had it all working.
That's great. Okay, this one's on now.
Yeah, this is on.
Hey, we're good.
And I will zoom in. I know there's a lot of numbers, so I will zoom in. But the nice thing about being self-funded again is that the health plan itself can kind of ride independent of typically what is your biggest cost driver, which is the reinsurance aspect of it. And each year we take your group out to over 30 A-rated stop-loss markets. And this year, actually, there were quite a number of carriers that quoted on your group. As we talked about last year, you're currently with a stop-loss carrier called Companion. And we are going to be recommending another change this year. There was just another stop-loss carrier that came in that was a little bit more competitive. And so I'll go into that. But from an overall perspective, I mean, the city actually ran fairly well this year. Towards the end of last year, we saw a fairly large increase in claims utilization, really Q4, which is oftentimes expected. And then looking at your claims trend for January and February, it has tracked back down. So that will kind of go into, some of the calculations in terms of funding. But the renewal itself, let me kind of take you in on this. And I'm going to kind of hone in on our two most competitive quotes and kind of explain the differences between the two and ultimately why we made a particular recommendation. But zooming in on this, one of the carriers actually will probably sound very familiar to everybody in here because it's the actual entity that actually does your 401ks. So Voya was actually one of the stop-loss carriers that was actually very competitive on your group. I'll kind of take you through and just kind of point out, again, just a couple of things for quick clarification. So the city's been on a $110,000 specific deductible for some time now, basically meaning that the city of North Platte basically incurs the first $110,000 of each individual member claim. And then on top of that, we have a $135,000 aggregating specific. So what that basically means, boiling it down to its essence, is the city's responsible for the first 110 of each member, and then the next 135,000 whether that's one person or 10 people. So that's that, but it's just the next 135,000 that exceeds the 110. I know I just threw out a bunch of numbers. That kind of, makes sense. Perfect. So everybody is quoting like terms. So you have 110 with a 135K aggregating spec. Voya is matching those terms, but then both carriers actually quoted on adding an aggregate deductible. And I'll kind of go into that. So really, I'm honing in basically on option 7 and option 9 from Berkeley. Those are the two, most competitive carriers. The main difference that these carriers are both offering that's an advantage to your current contract is both a plan mirroring endorsement as well as a no new laser with rate cap option. Kind of walking through what both of those are is...
I'm sorry.
Yeah.
I do not know. These are terms of art for you. I don't know what you're talking about.
Yeah. Clarifying what both of those are. So a plan mirroring endorsement. There's a policy that the that the city has, which is your summary plan document that basically outlines what you do and do not pay for. But then your stop loss carrier will come in and also issue a policy saying what they do and do not cover. And in some rare instances, there can be a gap between those two policies, meaning that the SPD says one thing, but the stop loss policy says another, and that creates a gap in some cases. Now, up to this point, we've had an ERISA attorney basically review both the SPD and your stop loss policy to make sure that there isn't a gap. What this provision basically does is the stop loss carrier is agreeing that, hey, I'm going to issue a policy, but that policy is basically going to say, we look at the governing summary plan description, your document, as the governing document. So it's just an enhancement that helps continue to protect the city from any type of gap in any type of policy. Does that help?
Yes.
Great question. The second one is a no new laser with rate cap. So as you're familiar, is anytime that there's a known risk, insurance is protection against the unknown. And when there's a known quantity or something known that's happening, what the reinsurance carrier will oftentimes do is say, hey, I will place a specific deductible on this one individual member that's going to be above the $110,000. What Berkeley and Voya are both saying is that next year, we will agree that we won't laser anybody and that we will cap our premium increase to no more than 50%. Now, a no new laser with rate cap is nice sleep at night insurance, if you will. Again, there's a reason why we shop with over 30 A-rated stop loss markets each year, and that's because oftentimes we can get another carrier to bite off on that risk. It's all about selling the risk that you have, helping the carrier understand the story and what's going on. So do I think that the no new laser with rate cap is the end all be all? No. But is it good potential protection for the city in a worst case scenario? Absolutely. There's a lot of new things that are coming out into the market, specialty medications, particularly as it relates to gene therapies, that can be in excess of $1 million. And so there's a lot of lasers that can pop up that would be in excess of, could be in excess of $1 million. And that's where this could actually come in a rarely rare instance like that could actually, potentially help save the city from a catastrophic renewal. Does that help answer any questions that might relate to that? So again, it's not earth shattering, but I think it's a good provision. I think it's a willingness, both the plan mirroring endorsement and the no new laser option. I think both show that Voya and Berkeley want your business, and they're willing to just throw in some sweeteners, that kind of helps sweeten the pot. Yeah.
You mentioned specifically gene therapy. Is that something that's already included in our policy coverage?
So if somebody were to go in and get a gene therapy drug, then, again, it meeting all the criteria for that drug, then yeah, it would be approved. Does that help? Is that kind of where you were going with that question?
Well, I'm not sure. I mean, are you saying that if I was to go to the doctor for some type of gene therapy remediation for something that I'm suffering from, is that automatically covered?
So it would be covered. And again, I always throw in the caveat that, again, meeting medical necessity, it would be covered. But maybe where your question is going is if somebody went in, if John Doe went in today, we already have a firm stop loss renewal from the carrier. So anything that basically happens from now until next renewal is going to be covered. But what I'm talking about with a laser is now next year at your next renewal, the carrier could still say that gene therapy drug is covered, but the city's going to pay more for it. Is that kind of where your question is going? So it is covered. It's just a matter of how much the city bears in that responsibility.
So are there any restrictions in our insurance of some procedures that may not be covered?
So that's why you have Quantum Health that does all of your pre-certification. So we're always looking for medical necessity. So again, we want to make sure that we're looking after the taxpayer and making sure that we're covering what should be covered and denying what should not be covered. Now, I guess what I would just say in your question is, because you're self-funded, there's really no dog in the fight from Quantum to deny claims. There's no reason for them financially. There's no reward for them. However, the city does have a fiduciary responsibility to the plan assets and to the taxpayer to approve things that would be deemed necessary. So, yeah.
One thing I just add to that is the plan document actually runs through in much greater detail what's covered, what's not covered. What I would say, just being in here and a part of things for the last 15 years or so, your benefit plan is actually quite generous. It covers more than the vast majority of plans that are out there, but there are some things that it will not cover, things that are deemed, experimental, those types of procedures. Once again, to Spencer's point about being good fiduciaries, there's a responsibility there to ensure, hey, you know what, this is a tried and true or proven type of procedure versus, hey, anything that anybody wants will be covered. We just want to make sure that the city is taken care of and just good stewards of those dollars. But yeah, I would say without any hesitation that your plan is actually more generous than 95+% of the other group plans that I work with. So it's a really nice plan.
So I have a question kind of along that lines, I think. So elective treatment, surgery, or whatever, is that covered? Does that have to meet a medically necessary criteria or not?
Yeah, they're a great question. So there are certain procedures that will require what's called, and this is typical of any program or plan, just prior authorization, running in, making sure that, it's a covered procedure, working with Quantum, the doctors should do that reach out on those types of procedures. But yeah, depending on what it is, I would tell you, once again, it's there are very few things that would not be covered or would not be considered eligible. We actually have a report that we run through on a regular basis with the committee that outlines, hey, here are some dollar amounts or here are some items that are not covered. And I think almost without exception, those dollar amounts are pretty much nil. So, yeah.
Let me just ask about the category of cosmetic surgery. Of course, there's cosmetic surgery in the case of an accident, and that's nearly always covered. But cosmetic surgery, that's a preference.
No, it would not be covered. It would be covered if there was, to your point, an accident, some type of serious type of condition or procedure that came up that needed to be covered. But other than that, no, because that would be the, on the individual's side, more of an elective. I understand where you're going now.
That's where I was going.
Type procedure, and that would be something that the individual would need to cover on their own if they decided to do that. Great question. Thanks.
What about an elective abortion?
You know what? I would need to look into the plan language on that right off the top of my head. I'm not sure what the plan language reads on that, but we could look into that.
I would like that.
Oh, yeah.
And what
Absolutely.
about elective gender reassignment surgery?
We will look into that as well. We can answer it in this meeting. We'll just pull it up.
Yeah. Do you want? I know this is supposed to be more of a work session, so if you guys want to talk about insurance, we'll gladly oblige. I'm fairly certain, Ed, to your second question, and I'll double check your plan document. That one, I'm almost certain the answer is no. And it might be worth maybe a little bit more of a discussion point. I don't know how much we want to get into that. Pull pull up your plan document. And we can, so what I'm pulling up, just for everybody's reference, is I'm pulling up your summary plan document. This is when we talk about the underlying document that basically controls the health plan. This is basically what we're talking about. It's a 108 page document that basically outlines this is what the city does and does not pay for. So I want to make sure I'm pulling up the right one. Now, we've made a couple of amendments to it. And so there have been some changes.
And one thing, well, Spencer, while you're pulling that up, one thing I would just say is one of the nice things about a self-funded program is that the committee and you, as a city council, have a right to adjust or make changes to the plan document as you see fit. And we'll obviously counsel and say, hey, we wouldn't do this, we wouldn't steer over here because of the following reasons, or, a lot of people are doing this and this may be something that you want to look into. But from an overall perspective there is flexibility. So.
As it relates, so I want to just I guess these are good questions that are being brought up. And the only reason that you're going to hear some level of just concern as I give answers is I don't want the city to at any point be opened up to anything that, could cause the city to be litigated against. So one of the challenges, particularly with the second question that you asked, right now it's not covered. But that doesn't stop somebody from, raising some type of challenge to that. What we're finding is in some cases that's being upheld by, various different judicial courts. I guess that comes down to a risk tolerance that, the city wants to have in terms of what is and what is not covered. But I will tell you, if you talk to some individuals, they would highly recommend covering those things just out of sheer caution. I know that's a very opaque answer, but does that answer your question in a very generic way?
Well, I appreciate that it's not in there. Yes.
And just so you know, that's more in line with most plans currently.
Okay.
Not saying what will happen in the future there, but as of right now, that's how I would say the majority of plans are currently set up. So, if that's helpful.
And then the first question is those are currently not covered either.
Okay. Thank you.
So just as what I'm looking at here, let me just zoom in, and I'm just going to speak more generally speaking. So in your summary plan document, and again, happy to share this document with anybody. Again, it's a lengthy read, but in there you'll have all of your eligible expenses, what is covered, and then you'll have general exclusions and limitations, what is not covered. So this kind of goes more to some of the questions you were asking, and you'll see item number 1 answers the one question that you had.
Sure.
And so as of right now, that's not. But to Ryan's point, I guess I want to make sure, again, the beautiful thing about being self-funded is we want to operate the plan as the city would want it to be run. And so if things are in the exclusion list that you don't want, and it may not just be some of the questions that have been asked already, there may be some other things as you run through this that you're like, hey, maybe we do want to cover this. I'll give one additional example, maybe for some context. So one thing that most health plans do not cover that the city does is treatment for morbid obesity. That was a change that the city elected to change a few years back. So the vast majority of our health plans don't cover it, but the city wanted to, and so there's some limitations in it. There's some requirements to actually qualify for any type of those procedures. So it's not just a kind of an elective surgery as we talked about. There's some stipulations on BMI, how long you've been working with a practitioner to try to lose the weight. But ultimately, if they go through those different circumstances and scenarios, it would be covered to have that procedure done. And I know some people have actually been a recipient of that. So that's just, again, one example of something that the city said, hey, we want to change that. And so we did. So I guess what I would recommend is, like I said, I can send this to Lane after this meeting. And I would encourage everybody to, run through this document, specifically what is covered, what is eligible, and what is not eligible. And if you see something in there that you don't like, raise it and we can make that change. Those are things we can, we can change mid-year. So,
Where do we stand on medications that are being used for weight loss that aren't really intended, such as the Ozempics and things like that?
yeah. That one again, so I use the term medically necessary. Right now the Ozempics would be covered. They're an eligible medication, but they do have to go through a prior authorization process first to make sure that they would be considered or deemed medically necessary for that purpose. And again, kind of going to a bigger point that the mayor's bringing up, is there's some of these medications that have been intended for other purposes, where they have discovered that there are some other benefits, such as weight loss. And so people are using it as such. So again, that would be a case-by-case basis, but Ozempic, in a short answer, Ozempic is covered and would just have to go through PA on an individual level to see if it would be approved.
But are there any limiting criteria when it's being used for weight loss? I'm asking because this is putting some places out of business. I mean,
Yeah.
University of Texas and some other places have limited their Ozempic use because they had so many people on it. It was costing them millions of dollars a year. Because it's about $20,000 a dose.
Yeah. So maybe best way to answer this question. I want to I'll need to dive in a little bit more. The mayor does ask a good question, but let me, what I'm going to do is actually just look at your spend. So the website that I'm on right now, basically is looking at all of the medications. And so, actually it's on that first page. You do have an Ozempic that's on there. Now we are actually procuring that Ozempic for, total cost of about $8,575.32. Now, you have 5 individuals that are taking that, with 9 total claims. So we're not seeing that same, I want to just, before I finish that, I want to agree with the mayor. Ozempic is not inexpensive. It's very expensive. Now, we're not necessarily seeing that same cost on the city's plan. And I can't say for sure that these particular Ozempic cases are specifically for weight loss.
Right. There are some valid uses around diabetes. Yeah. And it's a wonderful drug for people in that situation.
So, but I can look to see if, I want to see if I can actually maybe dive a little bit deeper into that to see if it's actually, try to find out what it's actually being prescribed for. So I can take a little bit of a deeper dive in there. So fortunately, we're not seeing that level of cost with your particular example.
But as it sits today, if
As it
someone
sits
was prescribed it for the purpose of weight loss, the city's plan would pay for it. Is that correct?
I want to double check that.
I don't believe it would.
Okay.
We'll confirm that. We'll confirm that specifically to this plan. I know that most plans that we have set up, they have expressed that it not be covered. And so that is the case in most plans that we work on. So I believe that's the case here, but we will circle back with you on that and confirm. Yeah.
And like I said, for those people with diabetes, it's a tremendous drug and they
Yes.
should have it. I mean, it does fantastic things for them, but as a weight loss drug, it's
Yeah. Hence the pre-auth. There's a lot on that's actually, I was going to say a fun topic, maybe not so fun topic, but the potential detrimental long-term impacts that can occur from the use of that for that type of situation, if it's not a diabetic type situation, can be pretty harmful. It goes to a bigger discussion also, which would be interesting to have someday, just in terms of what is being approved, by the FDA right now on a national basis. What's being pushed through, I'll just say it's adjusted from our perception, what was once upon a time probably a much more rigorous vetting process to, there are drugs that are being approved right now that in some cases are being pushed out before clinical trials are completed or even partially through. So it does require some, more judicious looking at those drugs and looking at the efficacy and the type of impact that those drugs can have, especially with those specialty drugs, because those can be, in some cases, You know, I've been familiar with one that we've been working on this past year, which is it's over $1 million drug each year. And I won't go into the specific condition, but the condition that it treats, the clinical trial has not been completed for that. All the studies that are out there so far indicate about a 1% delta in improvement in, mobility that the individuals experience. So minimal, positive impacts, almost negligible. And yet, over $1 million spend. So lots of discussions and conversations that are occurring right now around those types of specialty drugs. So
Thank you.
thanks.
What happens in the future when this drug is okayed as a weight loss drug? I mean, my understanding they're prescribing it now for that, but it's not actually been approved by the FDA or whoever does that.
Yeah.
So are we?
Great
what's it gonna
question.
do to our rates then?
Yeah, great question.
Because this is going to happen.
Yeah, and that
Bet on it.
yeah, for sure. And that's one of the great things once again about being self-funded is there's a greater level of autonomy in terms of how certain procedures, certain drugs are being treated. So there should be some autonomy still there, unless some additional legislation comes through that would allow the city to make some decisions on what they want to do there. The other thing that I would bring up, and it was illustrated in some of this reporting that's up here, is that with a lot of the cost containment solutions that we've brought to bear with the plan for the city, it has brought down a lot of those costs of those higher drugs, especially targeting specialty drugs, down very significantly each year, to the tune of hundreds of thousands of dollars that we're bringing those costs down. And quite frankly, you guys have a pretty good drug spend overall compared to your medical spend. So if, let's just pretend, and hopefully not, but down the future, let's project forward a few years and say, hey, specialty utilization has upticked quite a bit. There's still a lot of tools in the toolbox, so to speak, that we can utilize with your plan, just based on the flexibility there, to get those costs down significantly.
Okay,
So
we do have.
yeah, for sure, absolutely. Yeah.
I think to Ryan, maybe just continuing down this road, pharmacy spend, I think going into the future is something that keeps quite a few folks up at night as we talk about what we see, again, some of these, high cost specialty meds, and the city's not immune to some of these drugs. Again, kind of we're departing from the mayor's original question about Ozempic, and we're kind of broadening that discussion out to just generally specialty meds. Using the city's data, and this was actually going to what Ryan specifically was kind of alluding to, and I want to put some numbers behind it. So going all the way back to 2021, and let me make sure I'm zoomed in here because I want you to be able to see this. If you look at what the city could have otherwise let me zoom in. What the city could have otherwise spent on these various different medications, and I'll give you a few quick examples. But the city avoided almost $700,000 in pharmacy spend by, in essence, negotiating directly with the manufacturers. There's a lot of ways that we can control and manage your pharmacy spend, and this way has really bore a lot of fruit in terms of just overall cost savings. I'll give you some more specifics. So, like, for example, you have right now an individual who's taking a medication called Skyrizi. You might be familiar with it. It's a medication that you may or may not see at night as you're watching the evening news. They have a lot of commercials. And the cost of that medication, just the raw dispensing fee on that one, is $17,354.04. That's how much it would otherwise cost. We've been able to negotiate directly with the manufacturer on that medication. And we've been able to shave that one down to about $12,000 that we are actually paying for it. And that's just trying to negotiate directly with the manufacturer of that drug. A few others that kind of pop up. You've got another one called Renewal. This one's a little bit of a nicer story because we've been able to actually get that for no money towards the city. So that one is at a normal cost of $16,158.33. So I mean, these again, we're talking month. Yeah, that's for a 30-day.
Assuming that I was.
Now the revoke, this one in particular, this one is 90 days. And just clarification. This one revoke, the Skyrizi is for 56 days supply. All that to basically say, Humira, I mean, some of these drugs we've seen on here for some time. Humira was costing $19,614.09. That was for an 84-day supply. I mean, again, the city has no shortage of very high cost medications. And basically kind of maybe backing up and kind of looking at the big picture, what we're here to do and why we do what we do is the platform that I'm referencing right now is something that we've homegrown, where we get notified basically if there's a high cost specialty med and if there's something that we can do about it. And so we will actually target and pop up on this list and say, hey, we either need to be doing what we call alternative funding or PAP, or even internationally sourcing that medication. So I like to say, I mean, I know we're in a city council, so I know politics is something that, you're accustomed to. Healthcare seems right now to be running parallel to politics. And what I mean by that is just at the beginning of February, there was a Senate hearing talking about pharmacy spend. And a lot of these medications that we're talking about are designed, manufactured, and packaged here in the United States. And then they are shipped to other countries. And those other countries put price controls on those medications. And so it was brought up in the Senate hearing. Why is a medication that's designed and produced here in the United States at a spend of $80,000 here in the U.S., but you can go to France and pick it up for $17,000? And that's, again, simply just, the price controls that they have. Now, we can argue, should our elected leaders do something about that? I would argue and say yes. Are they going to? I don't know. I mean, I think this has been an issue that's been in everybody's face for some time and nothing has been done. But that doesn't stop the city of North Platte from doing something about it now. And so even today, we are able to ship medications to your members from tier 1 countries. So actually, a few of your members are actually receiving their medication from Canada. And it's just being mail ordered straight to their home. And again, this is a real challenge, speaking even locally. Again, we don't want to take business away from local pharmacies. But when you're talking the difference between, in some examples, especially with international ARCs, I'll just give a couple of examples. When, we're paying, $33,000 here for Jardiance, but we can have it shipped to the member's home for $9,000. That's a substantial, I mean, that's, again, where you get into the argument or in the discussion of the Department of Labor is starting to crack down on health plans for not meeting their fiduciary responsibilities. And what that means is that you have an obligation to your health plan to make sure you're getting everything for the best and or reasonable cost. One ironic example that I would give you is it just actually is somewhat of a recent lawsuit. I think everybody in here is familiar with Johnson & Johnson, manufacturer of a lot of different medications. Their own employees just initiated a class action lawsuit against Johnson & Johnson for hacking or jacking up their pharmacy spend. And actually not meeting their fiduciary responsibilities to control pharmacy spend. So you have a pharmacy company being sued by their employees for not controlling their pharmacy spend. Just a little bit of an interesting anecdote. So again, this is an area that we take very seriously in trying to control and manage that expense in the best way that, again, is good for as many people as we can. Any other questions?
Yeah.
Ty.
Hey, Spencer, on this topic, is there any correlation between people using less traditional methods of working with their physicians, such as telehealth or clinic safari, things like that, in conjunction with more aggressive specialty or newer drug use? So, in other words, if city employee opts for telehealth options or other things other than going to their local doctor, does that correlate to more expensive, aggressive drug use?
I wouldn't know. So, Ty, that's a good question. I don't know the answer off of this, but what I can tell you is I can look at and have it your all of the physicians that are prescribing on your plan. I have who that is and how much is being spent in their different location. So at a very, very quick glance, looking at your plan, looking at your highest prescribing doctor. Now this one is out of Omaha. Total spend $33,327. Most of your other prescribing physicians are here in North Platte. So I would like to look at that a little bit more, but I would tell you just at first look, I would say, at least particularly for your group right now, that I would not see.
Is that something you would see if it developed? Is that something that would create red flags on you guys' end? If you,
The only one that would come to mind would be like narcotics. I mean, that's what we're flagging for. So we're flagging for where it's being prescribed from, pharmacy, if it's being filled in multiple pharmacies. So we're geared for narcotics abuse, but maybe just general overall overprescribing of non-narcotic items. It would flag on this report, but I don't know if it would necessarily trigger an automatic flag that, hey, we have a problem here. But this is reporting that I do review on a quarterly basis. And if I'd started seeing a doc popping up here that was out of New York, and they were prescribing hundreds of thousands of dollars, it definitely would raise an eyebrow.
okay, no, you've answered my question. Thank you.
You bet.
You guys keep an eye on that.
That was maybe a bad example. I will amend that statement. Some other state. Maybe, yeah. Anyways, I'll leave that. But that's a good question. So yeah. Any other questions? These have all been really great questions. Okay.
How do you how do you define medical necessity? Is that defined in the SPD, or that's where it's all laid out in there?
Yeah, and some of them, like, I'll try to give you as many good examples as I can. You know, one where medical necessity comes in a lot is like cancer treatment. And so the NCCN is basically the foremost governing body, if you will, on cancer treatments. You have prostate cancer. This is the recommended course of treatment. This is the chemo and radiation therapy you should use. You have breast cancer, you have colon cancer, whatever it is, that's who would be publishing guidelines of this is what we would recommend. Now, if a member brushes up where they don't believe that, so let's say that somebody is, heaven forbid, diagnosed with cancer, and their doctor recommends a certain level of chemo and radiation, and those numbers, working in this industry, I'm discovering doctors have a lot of play over what type of chemo is being used, how much radiation, all of that is very customizable. So they submit a plan to Quantum, and Quantum's going to review that case and say, well, hey, based on what we're seeing, this would not be a recommended pattern or path for this type of cancer. The member can appeal that and say, hey, I disagree, and here's why. The doctor would submit notes and say, hey, here's why we would do this. And then step 2 would also be a peer-to-peer discussion.
That's all through the pre-auth.
That's all through the prior authorization. So then eventually you're at the point where a medical doctor is speaking with a medical doctor. This is why this case is unique and different, and then ultimately could be approved. So medical necessity is hard because it's not per se outlined directly, like if you have colon cancer, this is the treatment. We're using guidelines such as the NCCN to kind of come up with that path for that treatment.
But is the SPD the ultimate authority, or is Quantum Health? Where is the decision made?
So the decision is ultimately made with Quantum.
Quantum.
So they're using the SPD to
guideline.
review as the guideline. Right. These are the rules. Quantum's interpreting it.
Fair enough.
So now we may get to a point, and it's not uncommon that maybe the individual doesn't like Quantum's determination. The third level appeal actually goes to an outside board, not Quantum, to say and basically make the argument. So there's a really good path. There's 2 steps through Quantum to appeal a claim, and then ultimately the third one is a completely independent outside body to review the claim to say, yeah, we either agree with Quantum or no, we don't. We see it differently. It's a great question. Do we want to pause for a second, let everybody grab pizza, or do we want to keep on going?
I hope everyone's hungry.
Looks like we should
Yes,
be.
let's pause.
Okay.
Should we invite
Dinner.
the public?
Do we need another table down there? Do we need another table down there?
Yeah, we're all right. We'll just.
Okay. I just don't want to have to dig for my favorite pizza, so.
You put the cups on a chair or something.
They opened quite a can of worms, didn't they?
Pop and pizza and whatever.
Could have been.
Don't all rest the table.
Never paused.
I'm not.
Leave the path?
Yeah, women first. Somebody lead the way. Women and children, like everybody gets it. Blackberry. Yeah, right.
Isn't the worst idea.
So did Five Below open today?
Oh, I know.
I know it's coming up quick. Yeah, cool.
I've never been one before.
I haven't been in a pizza ranch.
I don't know why we're so
Boys were doing this.
we're not covered.
I think that's. That's what we were just. I probably won't.
Before they're more than.
I think I can scrape the, I'm not gonna eat the bread, but I can scrape the rest off, I think. No, I've sworn off the gluten.
I don't see any green peppers.
That's what I'm gonna do too.
I feel raised, but I
What's that?
What? It's not that right. That's what you gave up to.
No, I gave it up.
I don't see any green peppers. There was a joke about green peppers.
Yeah, been quite nasty. Yeah.
Right across the street. Tara. Yes, I am. Eating sweet slane, you need a
Yeah,
Tara.
get some.
So it was,
So you're-
it was the, yeah, they did affect me.
I'm sorry, but I would have gotten
No,
It's
that's
pretty
fine.
tasty, but
Is it good? No?
Mhm.
Good, yeah.
to represent the word too well.
Yeah, I know. You better. You know? Hey, Tristan looked pretty good in the first.
Yeah. I got my glasses, so I can bring them.
You hear my wife will get mad because I better come home and I'm hungry.
Oh, I know. I know. I'm glad. Okay, I do what you do.
I got a couple
I had my lab work done a couple weeks ago, so I could probably eat this. Wouldn't matter. I mean, they wouldn't know it.
issue?
Yeah.
So he has some. Yep.
Remember, you weren't gonna take me.
My immune system loves it. It goes into overdrive when I eat gluten. So I think that one drug he mentioned, I think is a heart medication to keep you from having a heart attack. That Jardins. My brother was on it, but the side effects were terrible. And he told me he wouldn't take it no more.
Pepperoni.
I thought it was only $643 a month. Takes what? And what does that do? Oh, for diabetes. Yeah, I don't know anything about diabetes.
Should I go ahead?
Yeah.
Thanks.
Oh, you don't mind it.
No, no. So one quick item I was going to bring up. We've discussed this in previous meetings. Our model, you guys have kind of been grandfathered in just based on the length of the relationship that you've had with us as healthcare experts in the arena and in the area. Vast majority of times we actually work through local brokers and brokerages. We thought as we were evaluating things that it made sense, had some discussions with Tanner. And anyway, we thought it would make sense to have a partnership there to allow some of that local representation here in town. It would allow greater access to individuals on the city plan who had questions to come in on occasion. We're still in the process of determining how we set that up, but to ask questions about the healthcare program, if something were to come up and we were hours away, so to speak, and we're not able to make it out here, he would be able to step in and assist on our behalf. So, variety of reasons for that, but we just felt like that made sense, and that was probably the right thing to do. I would say we're covering the bulk of that expense and that cost out of our fee components. So anyway, just something that we thought would be an enhancement to the city from that perspective. So
Partnership now,
yes,
and it's in this relationship.
yeah, yep. Any questions?
Wondered why he was here.
Okay, thanks.
You've all seen me before. So Tanner Patera with Hub International here in town. I also do benefits and P&C insurance here in town. And for years, I've been interested in the city's plan, and these guys have did a great job. I mean, 99% of what they do, we would recommend also. So we figured over the years since we talked, every time we come to one of these, that, hey, let's have a discussion on what's the best thing for the city. And having us work together, we felt would be a great thing for the city, because it's really not going to impact cost at all. And it gives the local representation, like Ryan said, that I can be here. Like the plan is eventually we'll figure out a schedule, but to have a day or two every quarter that I'm just available for employees that might have questions on their health plans, that sometimes you don't want to make a phone call, you want to talk to somebody in person. So yeah, and to be involved also, because some of my coworkers, right, some of our peer cities, so we have a little more data for peers compared to the North Platte size. So we just have a little more data that we can provide to help make decisions and guide the city down its path. So.
And he's available on a snowy day.
I am available on a snowy day. We did not close. We were open.
Yes, you were.
Maybe I just add a comment if that's okay. I was in the employee committee meeting where this item was discussed with the employee representation, which was probably about a dozen, Lane, and there was very positive feedback about having that addition of the local presence with it. At least that was the sense I got from the group that day.
Yeah, I think it'll be a great partnership just to improve the plan the best we can. I mean, health insurance is obviously not cheap and not fun, but it is very important to everyone. So.
Hence the reason we're sitting together now.
Well, we'll keep on, hopefully, keep on, asking questions, but I know we kind of went off on a few, I think, really good questions, and this is a work session, so I think it was all good and warranted. So I'll jump back into the renewal, unless anybody has any other questions. I know we had a lot of discussion about pharmacy in this country and a lot of other things, but does anybody have any questions before I jump back into this? Okay, great. So as I mentioned, really we're looking at two options, the Voya and the Berkeley option. So what I wanted to just, point out from an overall perspective is when you get down to fixed expense, they were almost neck and neck. They were basically, there's about a $2,000 difference between the two premium wise. Both are, right at about 707,000 or 712,000. That would be this column right here. That's actual premium going to the stop loss carrier. That's money, the fixed expense leaving the city, going to the carrier for that protection. Where there was a fairly decent discussion between the two. Now, Voya came in a little bit later, and so all the way up, leading up to this, Voya was kind of resistant to lower, particularly some of the laser liability. That's these numbers down here. So we do have a few people that are lasered. Now, I want to go back and clarify. Both carriers are offering a no new laser option. So they wouldn't be able to do this into the future. But there are two individuals that were of concern, actually relatively low level. Keep in mind that the $135,000 aggregating spec is also in there. So the laser liability is actually about $200,000. So it's actually a lot better than it's been in previous years. For example, so this year we're at 440. So that number is actually coming down. Hence the overall increase is at about a 2.4% decrease. Now, we're going to make the recommendation that you go with Berkeley. And the main reason being is that Voya was really dragging their feet to get to match Berkeley, and Berkeley kind of came there out of the chute. And so even though Voya kind of begrudgingly got there, we don't know if that actually speaks well to future renewals, since Berkeley was the one who said, yeah, this is, so it was Berkeley that was kind of the one that was always out in front, if you will. And still, end of the day, it's about a $2,000 difference to Berkeley's favor. So Berkeley is slightly favored. But I will tell you the back and forth with Berkeley. I mean, again, this is kind of where they came in, and we had to kind of drag Voya to get there. Both carriers are A+ rated stop loss carriers. They're both very well known. Berkeley is one of the largest reinsurance carriers in the country from a financial strength perspective. And so, we would at this point, from a renewal perspective, we would recommend taking the Berkeley offer. Again, all things being pretty consistent. Yeah.
Today, who are we with?
You're with Companion.
Companion. Okay, so both of these are new to us.
Yes,
So,
that would be correct.
Okay, just wanted to see if they were if Voya was dragging their feet, seeing where everyone was at.
So now, I mean, that's a good question. So we gave Companion last look. So what is customary in the industry is you give last look to the incumbent. One additional thing that I would just recommend or just point out that I think is yet maybe again just another tick. It's not earth shattering, but it is a nice feature is that both Voya and Berkeley are direct carriers. And so what I mean by that is a lot of stop loss carriers don't want to have a sales arm. They don't want to deal with it. They just want somebody else to do that work for them. So they'll subcontract out to what's called a managing general underwriter. Now, in fairness to Companion, Spectrum is owned by Companion. So it's one and the same company. However, it is kind of nice with Voya and Berkeley, as Berkeley and Voya are the ones who are selling the product and we're writing on their paper. But there are some, and you even see them on here, Nationwide, for example, with stop loss management. That's what we would call an MGU, a managing general underwriter, where again, Nationwide has ceded to stop loss management to basically write on their paper for them. And so you have two levels that you can go through if there's an issue. And so it's just, again, like I said, it's not major, but it's nice when issues arise, which they do from time to time. It's just nice when you're just on a direct contract. So, both Berkeley and Voya, that would be, again, if Berkeley was not direct and Voya was, and it was a $2,000 difference, I probably would say it might be worth the $2,000 to go with a direct carrier. But again, Voya and Berkeley are, pretty identical with everything that they've offered.
In your renewal process this year, still where you're shopping it with 17, 20 different carriers, are you seeing a trend here with Berkeley and Voya? Are you placing more business with Berkeley, say, this year? Is it something, are they trying to buy into this year?
That's actually a really good question. Both Berkeley and Voya, and maybe Ryan and Tanner, I mean, I'll give you my answer, and then, if they have any other additional thoughts. Berkeley and Voya don't buy business.
Okay.
They are very stable, very entrenched stop loss carriers. I would expect maybe more of that buying of the business from maybe some of the smaller markets. That would maybe kind of play into some of that. But actually, as I look at all of the carriers that quoted on your group, Companion is a very stable carrier. HCC is the largest one and a carrier that we've had you with prior. Granular, that's also, they have some pretty firm backing. I think we've talked about this previously. Granular is actually owned by Alphabet. And so, just kind of an interesting, side note there. And then, Liberty Mutual, Nationwide, Voya, Berkeley, those, and then HM are, again, I don't see anybody on here that's a smaller carrier that would just kind of be buying business. But
Just one other quick comment. So when we put it out to shop, we work with A or A plus or A plus plus rated markets, and generally what you will see there is much less of that tendency among those type of carriers to just come in and unreasonably try to buy up or purchase business. In fact, occasionally when we do see, stop loss quotes that is so out of the market from anything else, we will go back and vet that very thoroughly. The tendency or the hope would be let's grab that quote as soon as possible. Right. But just from experience through the years of 20 years of this, it makes sense to go back, make sure that their underwriting standards, they did their due diligence, they saw everything that was out there from a claims risk perspective, and then just confirm that, hey, they are in that cycle. And that's one of the reasons why we shop it with as many markets as we do. As long as they're AM best rated and they're high quality, high caliber markets, reinsurance or stop loss in your case, it's really a commodity. Yeah. When it boils down to it. And so it's just, ensuring that, they see everything, and then you're able to get those markets. And generally there will be 2 or 3 markets every year. Yep. Hopefully that'll come in much more aggressive than the others. And then to Spencer's point, we can really leverage those markets off of each other. And whenever possible, keep it with the incumbent. But when not, if they feel like they've been burned, right, which happens, let's move on. Yep. Okay. So
thank you.
Thanks.
Pete, I have one. I know what you do for a living. Mm-hmm. Stop loss is a commodity anymore that, unlike P&C where you get some loyalty and it helps down the road, switching stop loss frequently has become more and more frequent, and you always want to shop as many markets as you can, because you do occasionally get an underwriter that's like, hey, I like the group this year. Yeah. Let's go for it. So it's just vetting the market as much as you can is the way to do it with stop loss insurance.
All right, good, thanks.
So that would be, Berkeley would be our recommendation. That's who we would recommend. And I know we're not doing anything today, but that's, again, who we're recommending. Now we flip to the funding discussion. So there's the actual reinsurance portion of our discussion, and then there comes the actual, basically, how are we funding claims? Now, as I mentioned, one of the things that we noticed at the very tail end of last year. Now, the city. Let me back up and say the city has a very healthy reserve account. We're at about 3.3 million, we're happy with where the reserve account is. We always want to stay ahead of that. We don't want to be chasing our tail at any point. And so at Q4 was, when I say it was heavy, it was a very heavy Q4. And looking at January and February claims, you've tracked back down. But I still want to be very cautious as we look at what a budget for your claims reserve is. And so based on trying to account for trend, because of course expenses in 2024 are going to be more than they were in 2023. And even more so going into next year. And I'm just making a global statement. You have a number of battles being, a lot of, I would not want to be in a network. I would not want to be in any type of network negotiation right now. Just a couple of quick examples. There was a big one between Aetna and the University of Utah Health Systems in Utah. Their contract expired 2/1. They didn't actually get their contract negotiated till I think 2/14. after every member had been notified that, we're out of network, and that was a little bit of an uphill battle. I know United Healthcare is struggling with Mount Sinai Hospital System out in New York. The Wall Street Journal actually had an article about these very negotiations. They're happening all across the country, and there's a lot for that. So trend in inflation next year will probably uptick more than in previous years. So I want to be cautious of that and mindful. So originally we came to the city and recommended a 6% increase to the budget rates. Now that's coming off of basically 2 years of no increases, one of 2%. So this would be the first renewal in 4 years that we've seen a 6%. And mind you, again, not making any plan design changes. The industry would be at about 8%. So we're about 2% below industry, and we're not making any type of plan design changes, or I should say we're not recommending any. And so we wanted to go with a 6% increase. That was our recommended budget. That would put the city's estimated expenses next year at $6,505,731. Now, based on claims projections that we put together, again, using a very high watermark, that could potentially be about a $228,000 deficit, meaning that we would pull about $228,000 from the $3.3 million reserve account. I don't want to paint too rosy of a picture, but I don't want to paint too glim of a picture. Again, my claims factor is based on a high watermark. And if we actually do come off of that high watermark, I don't know if we'd actually would have a deficit next year. I just, like I said, it's easier to do incremental increases and taper those back versus not trying to be aggressive there and then playing catch up. And so that's item number one. But item number two inside of this is a part of our discussions is the employee council has really wanted to take a look at doing a 3-tier rate. Most employer groups, I think being, fair, most employer groups even do 4 tiers. And what I mean by that is you have a rate for employees, you have a rate for employees and spouses, employee children, and family. So most do a 4-tier rate. The city so far has been a 2-tier rate, meaning you have a rate for employees and you have a rate for families. And you actually have, looking at your employee count, you have 95 employees that take single only coverage, 77 that would qualify for what we would call an employee plus 1 tier, meaning that would be the employee and either a spouse or a child dependent. And then you have 65 families. So you have quite a few employee plus 1 individuals. To break that number down even further, of these 77, 75 are employee plus spouse. So again, I don't even know if a 4-tier would all, per se would be worth it, because you would have 5 employee children. That's something we can look at down the road. That can be a goalpost that we're looking for. But I mean, really right now, your demographics, I think a 3-tier rate would be very appropriate. Now, one of the challenges that we have is the 6.5 million target that we're looking for. That number doesn't change. We're always trying to target $6.5 million. So when you break up those tiers, you are basically, you have a lot of people in the family tier who are helping subsidize. And when you move them to a lower premium, that means overall lower premiums that you're collecting. So you have to kind of collectively raise the premiums to get that differential in there. Now, anybody looking at this would say, that's not a really big difference. We're recommending right now the single rate go to $1,139.24. We're proposing that an employee plus 1 rate be $2,000 and the family rate be $2,950. There's not a big difference. I mean, again, I'll even kind of zoom in a little further. That's not a big difference between the family and the employee rate. What we're trying to be mindful of is the impact that it has on the single rate and the family rate. So to put that into numbers.
So,
oh yeah, go ahead.
real quick, that's a monthly rate?
City, that's
monthly rate.
Yeah, monthly budgetary rate, not including employee contributions, because the employees contribute 80% or 20% rather. City contributes 80%.
That's the full premium amount, and then depending on
80,
the
20.
contract we're on, the fire and police have a little bit different split than that, and IBEW and public service have a little bit different split than that. But it's
Roughly that area. Okay. Okay, thank you.
So that would be the budget rate per tier. And then what that means to the employee so for the single, it would be about a 6% increase, 5.8%. So that would be a per paycheck increase of $6.35. The employee one tier off of current family rates would see a $10 per paycheck increase, and then family at 3.6%. And the family would see a $19.46 increase, which would be about 7%. In working with the employee council, this was something that they felt was agreeable to, and that these rates looked that we were kind of spreading that load. Now the question came up in the meeting, in the last meeting that we had, is that in theory there would be a little bit more of a differential between the family rate and the employee plus run rate. And the idea of what we're proposing is, let's get on the train, and in subsequent years we can help kind of make the rates between the family and the employee plus one and the single rates, we can kind of start steering those rates to where we want them to be. And it's easier to do that incrementally over time versus in one just kind of big change. And so everybody felt like this was a good proposal, and everybody on the employee committee felt good about it. So in addition to renewing with Berkeley, our go ahead.
On the single rate, do you know how many of those people actually have a spouse who maybe gets their insurance from their job instead? I mean, would it, if we do offer the plus one, would there be a lot of those that could chip into that? That's kind of what I'm wondering.
It's so the city is besides the railroad, the city has probably some of the richest benefits in your area, and so a $750 deductible is very attractive, because you want to look at premium and deductible and out-of-pocket maximum, which your out-of-pocket maximum is in some instances where some people's deductibles start. So you could get into an instance where, and this is a good point, where if you make that premium attractive enough, then you might have more spouses taking coverage with the city, which could be good or could be bad. Yeah. So
If I could add, doing some research on this with other cities, some of the cities in Nebraska have stipulations on their insurance that if their spouse can get insurance from their employer, no matter what the plan is, that the spouse has to get it from their own employer, and the employee would only be employee and children, or just the employee themselves. We don't have that stipulation, but it is something that some places have.
To Lane's point, so the Affordable Care Act, just kind of going back all the way to 2010, interestingly enough, the Affordable Care Act said you as an employer are required to offer coverage to your full-time employees working 30 or more hours per week and their dependent children. For some reason, spouses were left off. And so there were some employers that didn't even offer coverage to spouses. I'm not recommending that, but I mean, again, you have that latitude to say, hey, if we get to that point, the city could say, if you have coverage offered to you by your employer, you have to take it. So that is something that the city could look at down the road, if we feel like that's a challenge that we're facing.
I'd just add one thing on that. So when I look at the establishments of these three tiers, the difference between the plus one and the family rate is super thin, to where it probably shouldn't move the needle as much. And you could also have it, the argument about widening it would be that if somebody had a spouse who could get it at their work, they might go get the insurance at the spouse's work, and then one of them would cover the child, or the plus one would cover the child. And so I think this was a kind of a tough year to layer the three tiers in versus the prior ones, because everything was going up. And so the consensus, or the mostly consensus of the employee committee, was let's not move anybody back. If we're going to add a plus one, let's just put a lesser of an increase in them, which they knew was going to have a real thin spread between the two. So I think part of it was that's not going to move the needle that much in this first year and what you're talking about. But if over time, if you have a good year, you could widen that gap, probably without anybody feeling like they've been mistreated too much, and start to try to get those tiers to where they're at and address those things, I think.
Yeah, my main worry was just that we would have a lot of wives go on the move up from single to that, and I don't know, I kind of think it might end up costing us a lot more, since we do offer such.
But today they could come in under the family at pretty much really close to the same rate.
Yeah, the monthly rate to put it just into monthly perspective, it's 590, 571, and then 227 on the 3 tiers.
And the employee contribution for the employee plus one's 285, where the family is 295, so it's just $10 difference on what's costing the employee themselves on that per paycheck.
Have you done any analysis on how many employees have spouses that could go get insurance at their places of employment?
That would be probably something that we'd have to work with payroll on. And I don't even know, sometimes, so that would be something we'd have to really gather that information on. So some ways that employers do that is they do what's called active enrollments. So every year at open enrollment, they say, we're wiping the board clean and you have to tell me what you're doing. And then oftentimes there you can have a waiver that says, hey, I'm not electing the city's coverage because, my spouse offers coverage. The city, because your employment is pretty long tenured, the city has generally done what's called a passive enrollment, meaning that unless we hear from you, everything stays the same. So that could be something we could take a look at, but it would probably have to be in the form of like a survey with the employees, kind of proactively asking for that information if that's something that we wanted to look at.
I'm sorry. Maybe Lane, you can probably tell this, but do temporary employees, are they offered this?
They have to be full-time.
Okay. Thank you.
How do union contracts enter into the spouse having other available insurance issue? Is that an item that's depicted in union contracts generally, or?
Right now, we don't address that any different than the rest of the city, but that would be something that would have to be addressed at the union contract if we did that, so.
We just offer insurance to anybody who's full-time, actively working 30 more hours per week. And how spouses are covered, again, you have some latitude there, so it would rely on whatever was negotiated.
And I haven't done the math, but just kind of off the top of my head, I would say that probably about 160 of our employees are covered by a union contract, and about 60 of them aren't. That's on here. So I mean, that's kind of the breakdown. As if you wanted to dig in that deeper, I could get more specific, but that's roughly.
Okay. So that would be our recommendation. I'll share, we'll make sure that this is shared so you guys have a copy of this and can take a look at it. So I'll share this document, as well as I think it would be definitely worth sharing the summary plan description. So again, I would welcome everybody to flip through what is eligible, what is excluded, and raise any questions that are there. I do know that maybe switching gears off of this and going into further discussion, this year I think has been a really good year. We've spent a lot of time with the Mayor's Council and evaluating different options for the city. And right now we actually feel pretty optimistic that one of the big things that we feel has been a big boon for your employees is care coordination and navigation. Quantum, I think, is again just an independent arbiter of helping your employees get what they need and answering some of those questions. And, quite frankly, taking a lot of burden off of your human resources department that, as of late, has been some turnover. And so I'm sure, not having a bunch of questions is probably helpful. But, again, going to the overall discussion, we didn't want to leave, the discussion about M&A, without, kind of that piece of it, because that's something that we have spent a lot of time going through this year. Actually, Ryan and I spent some time out in Omaha with a few of the representatives from M&A, really taking a deep dive into.
So if you want to go beyond kind of the back history of that, they probably don't know the discussions we've had with M&A and that history with the hospital and stuff.
Even backing up a little bit further. So I think that there's a lot of unique challenges that are present, not just in a rural community, but in Nebraska as well. We do quite a bit of business in Wyoming, and you can kind of see some parallels, between the two states, just with rural hospitals. And so one of the things that Great Plains Health has done is they have gone together and formed the Midwest Network Alliance, M&A. They've contracted with a third-party administrator called First Choice Health, and basically they've developed their own basically internal network. Now, being perfectly candid, they would not be the first to have done this. I actually made reference to the University of Utah Health Systems. You have a lot of local systems. The University of Colorado has their own health systems that actually, I kind of take that back. They just sold to Select Health, so never mind. So you have a lot of these local systems that are hospital-driven HMOs that have popped up in a response to try to, I think, again, it's the age-old question of trying to manage expenses while also having claims process and not creating such a burden for the hospitals as well. And so Great Plains has joined in with M&A, and so we've been able to have a lot of discussions directly with the folks at M&A, and I think they've been actually really productive. One of our, I mean, again, just being very frank, one of our big concerns is we would love for M&A to work with Quantum. And again, the reason being is we want to make sure, again, kind of going to the city of North Platte's fiduciary responsibility. We want to just make sure that, again, that there's an independent arbiter that's overseeing and making sure that the care that's being approved and recommended is, I think, in the city of North Platte's interest. And so we believe that if we can marry the two, that actually would be a really good benefit to the city of North Platte, with the two of those together in terms of overall discounts that the city is receiving from local providers here in town as well as other providers here in the state of Nebraska. But then also having that high touch white glove approach from the care coordinators. The reason that we weren't able to do something this year, I think, was pretty simple. We got down the road pretty far with First Choice Health, and I think it came down to a bandwidth discussion because First Choice Health would have to cede a lot to Quantum to make this happen. And to their, to their point, they were onboarding a rather large client that was absorbing a lot of their internal resources, and so the folks at M&A said it's just not going to work this year. But maybe I'll even let Ryan to kind of speak to this a little bit more, but we were given a very positive outcome that next year actually looks like something that this could be done. I don't know if you want to add anything.
I was going to say no and then jump up. I would. The only thing I'd add to that is we are continuing those discussions with them on your behalf. We'll be revisiting that probably fairly extensively in the next 8 weeks or so. To see what that looks like. It was a positive indication a little while back, but we want to make sure if that is still, or if that is a go, and if there are any changes to the outlook of that from a financial perspective for the city, and to ensure that there's plenty of runway if a change were to be made for this next year. So once again, not a 100% recommendation. Let's roll forward on this, but the indications per our discussions and in-depth conversations have been positive. We'll be revisiting that early in the year, and it will be hopefully one of a few different options that we will be discussing earlier rather than later. So that's the intent. Any questions on that? Okay, thanks.
Okay. I think we touched on kind of maybe some of the high level points. Does anybody have any other questions? I know this is all super fun stuff.
Did we bump up deductible last year from 500 to 750, or have we always been at a 750 deductible? I'm just trying to think of my time frame here, because in the industry, that seems to be the general trend. $750 today is not what it was 5 years ago.
Pete, I'll give you a little bit of a soapbox. I feel like I've got one. So,
And real quick, I'm not advocating it. I'm just asking the question.
No, it's a good question. So the national average deductible, so just the average single deductible in this country is $2,200. The out-of-pocket maximum, if I remember my statistics correctly, is there's a lot of good reports. There's a lot of good reports that show you where everybody's at. But I think 40% of Americans are covered under a plan that has an out-of-pocket maximum in excess of $7,000. So I agree, a procedure in 2023 is going to be more expensive in 2024. That's inflation. And unfortunately, like a lot of other things, you can't put less things in a bag and keep the price the same. So we can't have shrinkflation. So the only thing you can have is the price to go up. But you're met with another challenge, which is the average American could not afford an emergency $400 expense. So the industry, the challenge that you have is that you have healthcare costs rising and deductibles rising with it, and people who can't afford it. And so I don't think that the answer is you raise the deductible, which has been the health insurance industry answer. I mean, that's because that's the easy one. Well, you're getting a 15% increase. If we raise your deductible to $2,000, we can get your increase down to 6%. And so this goes back to the genesis of why we believe so passionately in self-funding is that, again, it at least gives the city an opportunity to control the actual root cause, which is the expense, like the pharmacy. And I believe we increased the deductible from 500 to 700. It was like 2 or 3 years ago. It wasn't last year. It was yeah.
It's been more than 5 because I've been here 5. It's been 750 that whole.
Okay. Now see, I'm even off. Anyways, thank you, Lane. So I don't think that raising the deductible is the answer.
Okay.
However, this is why we've been pretty sticky with making sure that whatever we're doing, we're looking at the overall cost for the city. And that's why we think, again, quantum has been very helpful in controlling and managing those expenses, as well as engaging with your population. I mean, I know we haven't talked about it too much, but I'll just kind of touch on some of the reporting. I think another challenge, and I'm just speaking generally at this point, which is one of the reasons, if you look at the 2 highest inflationary sectors of our economy, the two are, one is healthcare and the other one is college tuition. And when you actually look at the 2 of those sectors, the reason why they're able to increase at the rate that they are is because the consumer is actually insulated from the actual cost of the good that is being delivered. So when you go to college, you sign up for college tuition and you press some magical button and your tuition's paid for and it goes off into this over here and you'll pay it back later. Healthcare kind of works the same way, where again, the consumer is actually insulated from the actual cost of the care.
Good analogy.
And so, but what I would point to, particularly for your group, and again, I mean, I'm not going to sit here and say that your costs are low. I mean, the city has a benefit that's being used, and you have a fair number of people who are utilizing the benefit. And I do think, and if I'm being completely candid, there's a lot of people who come to work for a municipality for the benefits. And so that tends to drive up some of the cost. And I think that's just something that you have to recognize. But what I want to touch on is when you have more of an advocate instead of somebody who works for it. And I mean, the great thing about quantum is the city pays them a PPM. And that's what they make. So there's no financial, kind of going back to approving and not approving things. They don't really have a vested interest in that. 75% of your spouses that are covered under the city's plan are engaged with the care coordinators. I will tell you, in this industry, that number is utterly unheard of. Average in the industry, probably 10 to 15%. It's abysmal. And then so we look at, so we've got the breadth of connection. But then you look at the average number of phone calls, and I know it's super small and you can't see it, but we're averaging 11 phone calls with your employees. So not only are we engaged with 3/4 of them, we're almost having a phone call a month with your employees. I think one other just quick stat, again, I think what's going to help in healthcare, if we wanted to fix healthcare, it was help people understand the cost of it and be better consumers. Americans are incredible consumers when it comes to, you want to buy a car? I guarantee everybody in this room probably tells you, what truck you should probably buy. I have my own opinion as well. But if you ask them any other questions about their healthcare, they wouldn't know. But 94% of your high-risk members are engaged with quantum, and you have 17 of them. So 17 people are deemed high risk. They're all engaged with the care coordinators with 66% provider engagement. Moderate risk, 75%, you have 4. But what is interesting to me, and this statistic I say, I think every time I've stood at this podium, this number hasn't changed too much. Your low risk population, you have 209 that are deemed low risk. And again, it's all about helping people understand their healthcare. One of the things that we've really initiated in the last couple of years is a blood draw. And the powerful thing I think about that blood draw in particular is, again, it's just about knowledge, understanding what's going on, helping people understand their health concerns. And I think a lot of people don't even know that they might have a challenge. And so the great thing about that blood draw is, one, we're kind of notifying people, hey, you have a challenge. And then two, that data is actually going to Quantum, and then Quantum is actually also able to reach out and say, hey, I don't know if you know, your cholesterol's high. And again, just it's all about that knowledge piece. And then as just one other side anecdotal point, the big main areas for your group, hypertension, diabetes, hyperlipidemia, and coronary artery disease are kind of your big comorbidities.
So have there been a good turnout for this blood draw, for this? A lot of people come in and get tested for that.
Yeah.
Take advantage of it.
Yeah, and I can actually send some reports as well of just overall utilization, but we've had some good utilization. Now, prior to the program we're doing now, we were also doing a blood draw years before that as well. And I think some of it's convenience, to be honest, because the phlebotomist comes on site. And so it's kind of an easy thing to come, and have that done instead of having to go somewhere. So we try to make it pretty convenient, but your utilization is quite good of using that benefit.
What's the PMPM for Quantum?
We reverse it into a PEPM. Quantum does charge a PMPM. I will grab that for you. I don't have that off the top of my head.
So it is a per employee per month.
Yeah, I mean, so Quantum does charge, in full disclosure, Quantum does charge a PMPM. For
Okay.
everybody here, that's a per member per month rate. And then we back it into, because Meritain can only charge a PEPM, a per employee per rate, per month, per employee per month. So we reverse that into a PEPM, but I can get that.
Either one would be fine.
Sure.
It doesn't matter.
It's less than $11 PMPM.
Gotcha.
Do you track the duration of the engagement calls?
Actually, I think we do. And I could try to grab that for you.
Okay.
That's a good question.
I'm curious if it's 20 minutes or more.
It's a good question. I would venture to guess it's closer to 10. Quantum's average, I think, is 8.5 minutes.
And that 75% engagement, is that on an employee basis or is that a member basis?
So the 75, so that specific stat that I'm quoting, that is spouses. So we actually break it out. And and again, I recognize that this is kind of
So
hard
it's
to
just
see.
75% of the spouses?
So 75% of spouses. So 56% of your employees, 75% of your spouses, and then 30% of your dependents are engaged with Quantum.
And in these engagement calls, you're following up. Are you ascertaining that they're following the directions, going on with referrals and because that's the big thing in population health. You're doing population health for a fee base, basically.
Yeah.
So
I'm excited. So Quantum is actually introducing a couple of new things. So we take all the data. We take the medical data, the pharmacy data, the biometrics data that we're getting, and you actually create a risk score for these members. And anybody who's flagging as high risk, they're actually getting proactive outreach from Quantum. But one big thing that Quantum is introducing this year, and this is where I think AI can actually be extremely helpful. So Quantum is all about the human touch, having a human talking to another human. Again, the whole reason that we feel it's human interaction is a good thing. And so what Quantum is starting to roll out is where they actually have an AI bot that's on the phone call listening. And that really frees up the care coordinator to be able to listen to the member. And the AI bot's basically, at the end of every phone call, going to basically produce a task list to say, you promised this member this, and this, and actually be able to report basically a task list for the care coordinator. So they're not really having to take notes or listen per se to, I promised this or I promised that. It's having a conversation with the member. And then that task list gets populated. But the other really cool thing is it's going to enhance our reporting, kind of to the mayor's question. That's going to actually enhance our reporting capabilities because now we're going to be able to track what people are calling for. So we're going to have a greater insight into why people are calling, what they're calling about, what issues they're raising. Are they raising multiple issues? So it's actually going to be a really nice piece for our reporting platform. It's pretty cool. Yeah. So AI can be used for good purposes. So there's some good instances for it. And I think that's a good way to use it.
Could you clarify something? You mentioned earlier, there was some negotiations or something between MNA and First Choice. Now, is First Choice is what the hospital is using here locally? I noticed when I went to the pavilion, there were signs up about basically. Okay. That's what it is. I mean, I guess my question is, if you have an employee of the city and they need to go to the hospital locally, they can do that. They're not precluded. Okay, that's my question.
Yeah. So, in all these interactions, you have to have a claims payer, somebody to pay the claims. In your case currently, that's Meritain Health. So Meritain Health is the one who receives the claim, processes it, pays the claim, sends the bill to City of North Platte.
Okay.
M&A, the Midwest Network Alliance, is the group that got together. They contracted with First Choice Health to be that third-party administrator. So that would basically replace First Choice Health with Meritain. They are the claims processor. They are the ones who, issue the ID cards, the summary plan document, all of those things. So they're just the ones who pay claims.
Okay. Thank you. I just a little.
That's a great clarifying question.
Yes, Jim, since I don't work in this, I was sitting in the committee work, which had myself and Chief Reeves and a couple other people from the city been working on this. It's been really interesting to listen to the talk about the M&A, and I think that the way I'm seeing this, without being an industry expert, is that if we're hearing feedback that the employees are pretty comfortable with quantum working, that seems to be growing in trajectory. They're helping them with financial decisions. They're helping them with care type decisions. And it seems like there's a growing comfort and employees like having that help, especially where the city doesn't have a real deep HR department.
Okay.
The dilemma, I think, is that the network, which would basically replace what like Aetna's doing today, you'd really kind of love to be part of because it's your local hospital and you want to support them and their group, which the vast majority of the care that the city's paying for is going to the group that's part of this MNA. I remember the exact percentage, but it's a very large percentage of the cost of care is going to people that are already in this group. But this group is not necessarily set up at this point to work with Quantum, which we think the employees like and has provided a lot of HR support. And so, but the difficult part is if you're MNA, part of the reason you've done what you're doing is to try to cut out middlemen and lower costs and have more direct relationships with your clients. And so that's kind of the conundrum in all this. But I think the sense of the committee that we've been working on, and I encourage if Chief Reeves has any comments from those discussions too, but that I think everybody thinks that ultimately trying to get in this network, if they'll still have us and we still think we can lower cost and support local health care, would be very, very positive. But trying to figure out how you do that in coordination with the care coordination that the employees seem to really like and benefit from.
Okay.
So, Chief, maybe I'd welcome you to add because we've sat through a lot of discussions on this.
Well, I would just speak to the quantum piece. I don't know how long we've had that, quite some time. And I've been on the employee committee since its inception. If I thought there was one thing that really helped our insurance, helped our employees awareness, the education, the utilization, I think it's that piece. I think that one piece is probably, I've listened to this for 15 years and I still don't fully understand it. But they understand that piece. I mean, that's their go-to, and it's gotten to where, did you call care coordination? Did you talk to them? I even had one employee that said he thought his wife was jealous that he talked to him so much. So, so the employees are really engaged with that group, and it's been really good. It's been good as a department because, like you said, we had limited HR and everybody kind of winged it, and it's really nice to have that piece and just guide them that direction.
With that too, we've also been looking at the fact that the city had very much higher than what we thought were peer average costs per member, but through having lower increases than everybody else, the gap is closing. So to me, that's some proof that the system is is working to try to get us back to more of an average cost.
And Ty, just to answer your question, I mean, I felt like it was a good one. Roughly 56% of all of your costs since March 1st of 2022 have run through Great Plains. So, Nebraska Med, Brian, we can kind of go down the list, but certainly, I mean, put a dollar mark, it's $6 million that has run through.
And there's other pieces there that are all still in North Platte. They're just not on Great Plains. There's other doctors and things in North Platte. So there's like,
And- Yeah, as you go through this, I mean, recognize that this is an EIN report, so it's based off of the tax code, and you might have some affiliations and some other providers here. This is just based off of.
I think when we added up all the different local healthcare providers, is it more in the 80+% range as far as everything in North Platte?
And you just get some outsized procedures that run, eastward. And I mean, again, that's going to kind of skew some of that. But when you look at the claim counts and stuff like that, again, Quantum's not here to, I think the last thing that I would just mention is I think part of the reason, and we had some good discussions with M&A, it's kind of good for there to be just a smidgen of friction, maybe a little bit of sandpaper, in the relationship, having somebody say, I don't know if I agree. Disagreement is not a bad thing. It's a good thing. And so I think that's been some of the challenge, is that, again, we just want to make sure that our job, we feel like, is, to the city council and to the taxpayers of North Platte to just, again, make sure that we're doing everything we can. And then, again, I would just say, the DOL would even argue, the Department of Labor would argue that you have a fiduciary responsibility. So I think if we can make something work, I think we would have our cake and eat it too.
I think you mentioned something about longevity of employees or something like, I don't mean in age, I mean in employment. How do we compare with other communities? Is our retention of employees better than some of the other people that you work with, or can you determine that from the records that you have?
I'll be frank, a lot of this is anecdotal, but we work with quite a number of municipalities along the I-80 corridor. I mean, I'll just give a little bit of background. When I cut my teeth in this industry, it was Nebraska and Wyoming. And many of them were government municipalities, local hospitals, local counties, local cities. And anecdotally, without maybe looking into any type of reporting, I don't necessarily think that the city of North Platte is maybe unique, because, and what I'm drawing from is when we meet with some of the city administrators that we work with, and they'll talk about some of their employees. I mean, I think one of the municipalities we had, one of their employees, I want to say he was 70 or 80 years old, and had worked from the city since I think he was like 17 or 18 years old. So, and I'm not kidding about his age. It was like it was hard to believe sometimes. And so I don't necessarily think that the city is per se unique. I think that maybe looking but I would say my subset is probably skewed, because I think that that's probably something unique to Wyoming and Nebraska, to be perfectly frank.
Well, the reason I was asking the question, and I think, Ty, you mentioned about our costs might be higher than other municipalities per capita. And I was just wondering if maybe if we have a higher retention, we would have a higher cost just because of the age of the employee, if that would have any bearing on it.
The two, and again, I'm just making this is an observation, so nobody shoot the messenger. The two areas, if you're talking to an underwriter, the two areas of concern that they would have is they would say, if you have a large concentration of younger females and a larger concentration of older males, those are underwriting nightmares. And your population, your employee base particularly, is 75% male, with an average age of 47, which I would tell you is elevated. Is higher. Yeah, it's, I would say a lot of our groups are the average age, because again, you're talking average. I would say most of our groups reside in the low to mid 40s. And so, although it doesn't sound like a big difference, that few years actually does create a fair difference. It's a great question.
Well, I think that maybe points to something else too. I mean, it would seem to me that it points to satisfaction of our employees of working for the city.
There's,
I don't know, I mean,
Yeah, and I agree. I think it's very important. I think it's a good thing because you have experience. And, you have people that done the job, they're experienced, they know what they do. It's more efficient. I always feel that the local employees, that's my thought. Maybe I'm wrong, but I know when I had employees, I wanted to keep them. They know what they were, didn't have to retrain them,
Earlier you had a medical breakdown, where all the spend was.
Yeah.
Do you have an RX breakdown of both where the scripts are being written, but also where the scripts are being filled at?
I do. So I can look at, and again, hopefully just driving to yours. So looking at, I can break down pharmacy. So, and again, keep in mind that this is, I'm going to actually expand this data a little bit. I have it current year to date, but let's do,
Calendar year last year would be better.
yeah, let's, last year. So taking a look at last year, those are now, and Brad, I think you asked a couple questions in there.
I did.
So this would be a breakout of the actual pharmacies that are filling medications. And so again, one of the challenges that you have is those specialty, I mean, again, when you have a medication that's $17,000, even though, you have a pharmacy that's, being heavily utilized, such as Walgreens, for example, where you have 937 prescriptions being filled. Most of your pharmacy is going to, or most of your specialty meds are going to go through like a single source, like a Credo. And this is where, again, you kind of get into some other challenges. Some of the specialty meds that you've had, and I know a few of them in particular are what we call single source brands, meaning that the manufacturer of that drug only sells to one pharmacy. You can't go to your local pharmacy and pick up that medication. You have to actually procure it through a pharmacy such as a Credo. But hopefully this answers at least one part of your question, which is who are the pharmacies? So we have access to that data. Brad, and forgive me, what was I know there was a few questions.
Where the fill was like, so similar to like the medical spin,
Yeah.
but the where the script was written. Are those local doctors or are we?
Oh, yeah. So, and we've got these two tabs right next to each other. So these are the doctors where that's being filled at. So these are the prescribing physicians. And then right here, and I'm happy to, I guess I would welcome, if anybody has any questions on this, happy to run through this a little further. But, for a site, I mean, just looking at your data in particular for all of 2023, of the prescribing physicians, you can come all the way down here before you start getting to, a doctor in Dallas, Texas, and then one doctor that's based in Denver, Colorado. Almost everybody else is Lincoln, the vast majority North Platte, Omaha. So again, the vast majority of your docs that are prescribing medications are here. Does that help get you what you need? Okay.
Yep.
And I can, like I said, if anybody wants any more in here, happy to dive in. Pharmacy is a big area. Okay. Well, with that, we appreciate the work session. We appreciate the time. I think that this is important for everybody on the council to understand and know. I mean, again, I'm sure as a line item budget, I'm sure this is not a inconsequential part of your budget. And, again, it's something that we take very seriously. We feel like this industry, and we've said this before, but I'll kind of end on some of these notes. The reason that we exist as an entity is because we feel like that there is a lot that is broken in this healthcare system. And we don't necessarily mean that as a platitude. There's a reason why a pharmacy chain, i.e. CVS, bought an insurance company. There's a reason why the big BUCA carriers, and when I say BUCA, I'm referring to the Blue Crosses, the Uniteds, the Aetnas, the Cignas. There's a reason why they're buying up all of these small mom and pop TPAs, because even just 10 years ago, it was not uncommon to have independent third-party administrators that existed out there, but a lot of the bigger carriers, they're buying them. There's a reason why United Health Group has one of their biggest divisions is a pharmacy benefit manager. There's a reason why Cigna merged with Express Scripts. There's a reason why the Blues have an interest in a pharmacy benefit is when you peel back the onion of healthcare and you particularly look at what the Affordable Care Act has done to healthcare expenses in this country, I would argue from a very philosophical perspective that the ACA has done a lot of harm, particularly even just in and around the MLR, or what's known as the medical loss ratio. And that basically capped the insurance companies at an 80-20, basically saying 20% of your revenue from insurance premium can only go towards administrative costs. The other 800, so if you have a $1,000 premium, 800 has to go to claims, 200 can be retained by the insurance company. And I would argue that that was a good theory by some bureaucrat, maybe sitting inside the Beltway. In actual practice, terrible. Because what does that incentivize the insurance company to do? Increase claims, because if you increase claims, you can now increase the share that you have from your administrative costs. But there's actually an even darker piece beside that. Is it now just incentivize the insurance companies to start buying the providers? Because if you can start making money on the admin costs, but then you can also start buying the providers, then you can also start making money on the claim side. That's why United Healthcare is purchasing doctors left and right. And I think also is, again, if everybody's familiar, this wouldn't be the first time, but the DOJ opened up an antitrust investigation. Now, I know that sometimes that might be like, oh, sweet, maybe something's going to change. I think this is the 13th DOJ investigation. So, I mean, good luck. So we do believe fundamentally that there's a lot flawed in this industry, but there are a lot of ways to get around it. And again, having an independent TPA, having an independent PBM, and negotiating that contract at a very deep level is something that we're very good at. And speaking about longevity, I mean, I'll age myself just a small amount. This is all I've done my entire professional career, and I've worked for the company for 12 years. I really appreciate working in self-funded health plans. I mean, this is all we do. And it's mainly because I don't want to take the BS from an insurance carrier. I want to be able to negotiate independent contracts and be able to do those and look out for our clients' interests. So we really appreciate the opportunity. And all 12 of those years, as a side note, I have worked with the city of North Platte, even when I looked a lot younger than I already did. Although I think it's my kids that have probably aged me more than anything. So anyways, we appreciate everybody's time. We appreciate your interest in this. And again, Ryan, Tanner, and I are here, to answer any and all questions that you have. And we look forward. I know this is not like we're ending or closing a book. I know that this year we're going to have a lot more discussions and look forward to talking again. So anything else okay.
Anybody have anything else? Spencer, would you send us or send Lane a list of all the prescriptions by NDC number?
Sure.
For 2023, please. Anyone have anything else? Meeting adjourned. Thank you, everyone.
Thanks, guys.